Good morning, it's Dr. Rutledge, and talking about the mini-gastric bypass again. And as many of you know, I've been traveling around the world and teaching and talking about the mini-gastric bypass. And I've invited surgeons to contact me if they had questions. We've had videos of my interactions with surgeons around the world. And I wanted to talk about a patient that a surgeon who did a mini-gastric bypass on sent me a question about. This is a complicated patient with a complication that occurred and had a leak around the time of the mini-gastric bypass, and so wanted to make some comments about that. The patient and the physician and surgeon will not be named in the video, but it's a difficult problem and I wanted to make some comments about it. And so this is an email I received the other day. Dear Dr. Rutledge, this is Dr. DB. And I did an MGB about 15 days ago. Along with the patient had multiple gallbladder stones, so they did a planned cholecystectomy. They found a difficult intraoperative finding. The gallbladder was, quote, intrahepatic, and so many stones during dissection, the gallbladder was opened, stones came out. They managed to clear the stones, but, quote, it was difficult and the gallbladder took 4 hours to complete both surgeries, about an hour and 45 minutes for the MGB. And so immediately that should raise concerns in you, the listeners, because, you know, most MGBs take about 45 minutes by themselves. So 4 hours is a long operation, and this is the beginning of the problems. According to the email, quote, the problem started on the third postoperative day when they saw bile in the drain. And I'm not going to comment on this email until I'll go back and read through it later. But basically, as it was difficult gallbladder, we thought it would be a cystic duct stump blowout, so they just decided to observe the patient and not do any further interventions. Meanwhile, they did an oral gastrografting study which showed a smooth passage of dye into the jejunum, and particularly, it points out in the email, no leak. For around the next 4 days, the biliary output was not reducing, and so they thought of going for a MRCP, but the patient was unable to sleep in the supine position as he was getting breathlessness. And so those of you who are bariatric surgeons will know what this means. So the email, he's 140 kilogram and so not able to tolerate the MRCP procedure. So they went for a CT scan, which again showed normal passage of contrast in the loops and no other collection in the gallbladder fossa or the pelvis. There was a hemorrhagic collection, quote, around the liver. We waited for a week more, but the drain output was persistent, so decided to go for laparoscopy. On laparoscopy, they found the drainage tube tip was near the anastomosis, and there was quite a lot of fibrosis around it. After trying to separate around that area, we found a yellow capsule near the anastomosis. We did methylene blue test, which showed a big opening, that is a leak, at the gastrojejunectomy. And I was unable to go behind the stomach pouch and jejunal loops, so the surgeon converted it to open surgery. On exploration, quote, we made the anatomy clear. It was below the total gastrojejunectomy was sloughed out. There was a small collection between the stomach and jejunum at the posterior part. There was a vertical opening along the staple line from the gastrojejunectomy to the middle third of the pouch and around the first 2 or 3 staplers. So it was a big opening in the stomach vertically and then opened into the gastrojejunectomy. The surgeon says I refashioned the lower part of the stomach and vertical portion till I got good vascularity and then repaired it vertically and did the gastrojejunectomy again. As I did with all 2O PDS interrupted sutures and a feeding jejunostomy distal to our gastrojejunectomy about 1 foot. And his questions are, what is the cause of this big slough out of the stomach as vascularity of the bowel was normal? Why was the lower staples get sloughed out, and is there any problem with technique? Quote, number 4, as I feel it's ischemic, what do we do to avoid all this? And 5, sometimes we've seen that after creating a pouch, the pouch rotates and the staple line which was created on the left side becomes anterior. So the problem with the patient is created ischemia. Is it always recommended to do a gallbladder removal with MGB? And his main question, is it right for what I did for the patient or something more I should have done or something we may have missed? And thank you, sir. So we're going to make some comments. Going to read through that same email and I'm going to make some comments. And let me preface this by these are my opinions. And I think other surgeons might have different opinions. Obviously this is a great surgeon with the patient's best interest in mind, and gets into one problem after another, and one complication leads to another. So all my comments are in hindsight. You know, I've already seen what happens, so this is a biased viewpoint. But if you look at my published work, all the things I'm telling you are things that I have said before I got this email, before I saw this particular patient. So let's go back and read through that email again, and I'll stop and make comments as we go along. And I'm going to refer to other videos, and in particular I'll put some links to some slideshows where we talk in more details about preventing complications, at least my opinions and my advice for this surgeon and other surgeons who want to hear my thoughts. Again, dear Dr. Rutledge, I did an MGB 15 days ago, along with the patient had gallbladders. And so the first thing I would say is I recommend never doing concomitant operations with the bariatric surgery. And I have a very detailed discussion on this and a lot of videos and discussions on this. Many other surgeons do this, and oftentimes it works. But even if it happens like this in 1 out of 100 patients, this is a tragedy for this patient, who could have avoided most of this, I think, had they not had a 4-hour gallbladder surgery. Now, you can argue that 4-hour gallbladder surgery didn't contribute to this, but my bias is that patients who have concomitant surgeries with their bariatric surgery, and mine is an MGB, I recommend not doing concomitant surgeries. Very much, this is something I feel very strongly about, and I'm not critical of the surgeon for doing this. Many surgeons do this. I disagree, and I think this is an example of why I feel strongly this should not be done. Okay, back to this surgeon's email. He said, patient had the intrahepatic gallbladder, many stones. While dissection of the gallbladder was open, they cleared the stones. It was difficult, took 4 hours. Okay, and so my next comment is, after hearing this, remember again what I said, number 1, for a difficult gallbladder, recommendation number 1, don't do it. Don't get into that. It's not necessary. The patient has had that gallbladder for a while, and if they need a gallbladder surgery, do it separately, because the potential risk of the bile spillage may affect the healing of the anastomosis. And the next thing I would comment on is, let's imagine that you have decided to go ahead and you find, as this one is described as, quote, a difficult gallbladder. Well, immediately, because of your concern about this particular complication, my advice is do a cholecystostomy and get out. Don't be there for 4 hours on a sick, obese patient. Often they're diabetic, they may have pulmonary dysfunction, they may have other complications. Don't put this patient at risk, don't put the life at risk, simply put in a cholecystostomy tube. That will work for months, and at that point, the patient, say 6 months after their MGB, they will be healthier, their diabetes may be gone, their respirations will be better, and cholecystectomy at this point will be an easier and simpler procedure. Okay, again, problem started, back to the email, problem started on the 3rd post-op day when we saw bile in the drain. Okay, first again, remember comments number 1 and number 2. First of all, don't do it. Second of all, if you're doing it, it's difficult, do a cholecystostomy and get out. And third, my next comment is bile or any abnormality in the postoperative period, re-explore. Okay? Again, I have slides and videos on this. I can't emphasize this enough. I know that many surgeons do not do this. You see in this particular case, there was CAT scans and gastrographin studies, all kinds of different studies. All of this on this 3rd or 4th postoperative day, what would they have found if they had operated on day 2 or 3 when they first saw any signs of abnormalities? The MGB patients are blessed, and they routinely do almost perfectly post-op. Anything at all that's abnormal, re-explore. Because remember, re-exploration is nothing more than replacing the laparoscope and the ports. It's less time-consuming than a CAT scan. It's less uncomfortable than a CAT scan for the patient. There's no dye. And not only is it absolutely diagnostic, but it's therapeutic. And as in this case, this patient, as we are going to see and as we've heard in the email, had several studies showing there was no leak when the gastrojejunectomy was completely blown apart. Okay? Those studies, a methylene blue test intraoperatively at the time of surgery, post-operative studies are misleading and lead to misdiagnosis. So number 3, my advice, anything abnormal, in any case, just re-explore. because this is such a tragic complication. It's so easy to re-explore. So number 3 is re-explore. And we'll have my responses to this also written, available for you to look at. Okay, so as it was a difficult gallbladder, we thought it was a cystic duct stump, and so we just decided to wait. Again, re-explore. Meanwhile, we did an oral gastrographin, smooth passage of jejunum, and again, number 4, leaks can be present and not be visible on CAT scan. Leaks can be present and not visible. Leaks can be present and not visible. Don't wait, re-explore. Okay, back to the email. For 4 days, the biliary output was not reducing, so we thought of going for an MRCP, but the patient was unable to sleep in a supine position because of developing breathlessness. Re-explore. The patient's becoming septic. How else are you explaining this? Why are you going for a diagnostic test when the patient needs therapy? So my bias is that progression to sepsis is now obvious. It was actually obvious to the biased surgeon early on. That re-explore, re-explore, re-explore. You're going to have to re-explore. You had to re-explore. My opinion always is to re-explore. In this patient, re-explore. Okay, difficult patient. Again, they did another CAT scan, which again, quote, showed normal passage of contrast and no other collection of gallbladder, fossa, or pelvis. So this is again saying no leak. The X-ray study is misleading. It leads to misdiagnosis. Okay, there's, quote, some hemorrhagic collection around the liver. Well, hemorrhage, whatever, had they re-explored, this is where the leak was. We can be pretty sure now. So we waited for a week, but the drain out was persistent. So then, at this point, they decided to go laparoscopy. We all know this time frame now. 15 days post-op, this is the time when you have your most difficult surgery. And indeed, on laparoscopy, they found the leak. They found that the gastrojejunectomy was completely disrupted. The posterior wall of the stomach and the staple line was disrupted, and they begin to focus on this particular detail. That is all disrupted, potentially by a technical error. It's hard to say at this point, but it just could easily be necrosis from an infection that was localized in that area that was partially controlled by antibiotics. But the whole area is blown out, they take it apart, and now they do an operation. They do a debridement of the area and repeat gastrojejunectomy. And again, my bias, and this is more detail, explained in more detail in the videos and the slideshow, is don't do a repeat gastrojejunectomy, but debride everything and do a gastrogastrostomy. Take down the gastro-J, because that repair is very solid. Gastrogastrostomy, very solid and very unlikely to leak, whereas a repeat gastrojejunectomy leaves the patient in an area where they can't absorb all of the foods you would like them to. That is, they have a gastrojejunectomy, so the duodenum is bypassed, and now when they're trying to heal this, you have done a weight loss procedure. So my bias is take down the gastro-J, gastrogastrostomy, let them heal from this, and you can always come back. So, I did this all. Now is questions and my answers. So what is the cause of the big slough? Okay, my opinion is that big slough was just a mist leak, a mist-contained leak. All of his studies show there was no leak, there was a leak, but it was contained by the body, just like a perforated appendix, which is covered by omentum, a perforated diverticular abscess. We see this all the time. The CAT scan missed it because it's in the area of all the inflammation, and they said there was a collection of, quote, hemorrhagic. Yes, it was hemorrhagic, infected, hematoma, blood infected, bile leaking, 4 hours of surgery, ischemia, trauma, inflammation. So my bias is this is not difficult, it's not complicated. He raises the concern, well, is this some kind of very odd or unusual ischemia? Possibly, yes, I guess that's possible. Maybe the placement of a staple gun, maybe he chose the wrong staple height. In other words, maybe he's using blue on a very thick stomach and they cut through and they fell apart. All these are possibilities, but they're just very unlikely. The most common thing is it's a leak and it was missed. Why the lower staples came out? Again, it's certainly a possibility that it was ischemia, but more likely it was just a mist infection. And is there any problem with technique? Sure. This is an early surgeon. He's a new MGB surgeon. So yes, it's very likely that he has a problem with his technique because we don't see these kinds of problems as you become a more experienced surgeon. But again, add 4 hours of surgery. Add the twisting and turning that he describes, and there certainly is a possibility that he is tugging on the staple line, that he's crushing or tearing or pulling on the staple line, that he's using a mismatched area, or that he went quickly through the staple line, which had associated bleeding along the staple line. The hematoma there became secondarily infected, and that caused the necrotizing infection that caused the gastric jejunostomy to blow out. All those are possibilities, but those are not the critical questions. The critical question is re-operate early, and don't do things that make the possibility of leak higher, and an associated 4-hour surgery will certainly increase the risk of complications. Again, the technical issues of the MGB are worth considering. We have videos on that, and I'm not going to spend too much time on it. But basically, the MGB should be easy. When you're doing it and it's difficult, you're doing it wrong. So let me say that again. The MGB is technically easy to perform, but there are tricks and traps, especially surgeons who come from a sleeve background or a Roux-en-Y background. They often have a great deal of difficulty. They put too many stitches in to make the anastomosis tight. They twist and turn, they put the ports in different areas, the angles are wrong. So again, MGB is easy. When you find that you're struggling, you're doing it wrong, and it means extra time and getting better education, better knowledge about how to perform it. The MGB should be easy and straightforward. When it's not, there is a possibility of technical error. Yes, how to avoid ischemia? Well, again, it's port placement. You don't want to be twisting and turning the stomach pouch to create the pouch. If you are twisting and turning the stomach and having to angle and the staple gun, you haven't got the ports in the right place. You haven't done the dissection correctly. So stop, redo, relearn, spend extra time to educate yourself on how to perform this simple operation in the correct way. If it's difficult and you're getting twists, then that means you're doing it wrong. Okay, so that's what I would say there. Again, they ask about the twisting, and again, twisting is a technical error. It should lay flat. Otherwise, you are twisting and turning this, and of course, we see the same thing in sleeve, the corkscrew sleeve. So if you're getting a twist, that means you're technically doing it wrong. Okay, and then they say, is it always recommended to take the gallbladder out with an MGB? Never. Never. Again, I have done this for 16 years. There were a lot of surgeons who recommended concomitant cholecystectomy. Never do concomitant operation with MGB is my advice. So, difficult problem. We certainly wish this surgeon all the best. None of my comments are meant to be criticisms. It's just this is all comments in retrospect. And so it's easy to be critical in retrospect because you already know what's going to happen. If I said don't take out the gallbladder, 100 times out of 100, that's probably going to go safely without complications. But my bias is this can happen 1 time out of 100, even if it's 1 time out of 1,000. What if you could avoid this by taking away that 4-hour surgery? Also, the concerns about the technical performance. The MGB should be easy. If you have twists and kinks and ischemia, that means that you're handling the tissue roughly, twisting it or turning it incorrectly, and the MGB doesn't have to be that kind of operation. So you want to spend more time learning how to perform this so that it's as easy as it should be. I hope this is somewhat helpful. I was thinking of writing a response, an email, but I didn't want to type out this much, so hopefully this has been somewhat useful, not only to the surgeon who had this experience, but also to others. These are my opinions, and I hope it's been useful. Feel free to email me or call me anytime, day or night, if you have any questions. I'd be happy to try and help. Thanks very much.